Να προχωρήσουμε απευθείας. Να σας συστήσω τον κύριο Φαρμακιώτη που βλέπετε. Χαίρομαι να παρουσιάζω έναν άνθρωπο που έχει τελειώσει το Αριστοτέλειο Πανεπιστήμιο και προέρχεται από τη Θεσσαλονίκη. Είναι αναπληρωτής καθηγητής στο Brown University και είναι υπεύθυνος της μονάδας λοιμόξεων σε ογκολογικούς και μεταμοσχευμένους ασθενείς και θα μας μιλήσει για την επίπτωση του CMV στους ανοσοκατεσταλμένους ασθενείς. Κύριε Φαρμακιώτη, ο λόγος εσάς, ακούγεστε?
Ναι.
Μάλλον. Ωραία, τέλεια. Σας ακούμε μια χαρά και τις διαφάνειές σας.
Ναι, βλέπετε στην οθόνη μου το Providence και την Κρήτη. Είναι σίγουρα ένα από τα πιο αγαπημένα μέρη μας. Νομίζω ένας από τους λόγους που με παντρεύτηκε η γυναίκα μου ήταν οι διακοπές μας στην Κρήτη. Δυστυχώς, από την εποχή που ο Σίμος ο Μεταλλίδης μας άφηνε να βάζουμε λεβάν και να παίρνουμε αέρια στην αλφαπαθολογική του ΑΧΕΠΑ έχουν περάσει πολλά χρόνια, δεν θέλω να πω πόσα, και η ομιλία μου θα γίνει στα αγγλικά, θα μου επιτρέψετε. Ίσως ο μόνος λόγος που δεν βρίσκομαι στην Κρήτη αυτή τη στιγμή είναι ότι η κορούλα μας είναι μόλις 2,5 μηνών και θα με συγχωρέσετε αν κάποια στιγμή ακούσετε τη μικρή μου την κόρη να κλαίει ή τη μεγάλη μου την κόρη να γαυγίζει. Δεν θα μπορούσα να μιλήσω για το CMV χωρίς να αναφερθώ σε ένα μεγάλο δάσκαλο, τον οποίο χάσαμε πέρυσι, τον Φρανσίσκο Μάρτι από το Brigham and Women's Hospital, αναπληρωτή καθηγητή της ιατρικής σχολής του Harvard, που έμαθε σε πάρα πολλούς από εμάς λοιμοξιολογία ανοσοκατεσταλμένων και κάποια από τα ονόματα που βλέπετε εδώ είναι οι λοιμοξιολόγοι των ανοσοκατεσταλμένων στο McGill, στο University της Μινεσότα, ο Τάιλερ στο Seattle, Fred Hutchinson, ο Josh Hill, η Μπετίνα στο Pittsburgh, ο Γιάννης ο Κούλιας στο Κολοράντο, η Αλίσσα η Σάρα στο MGH, η Λύση στο Baylor, Texas Children's, and so on and so forth. Francisco definitely will be greatly missed. Ήταν επίσης ένας πολύ ταλαντούχος φωτογράφος και βλέπετε εδώ δύο από τις τελευταίες φωτογραφίες τις οποίες πήρε. Είχε ένα ατύχημα προσπαθώντας να βγάλει φωτογραφία έναν καταράκτη στο Dominican Republic και έπεσε στον γκρεμό. Certainly someone greatly missed and a great CMV investigator. So this is an overview of my presentations. I'd like to start with the bedside, take it from there to either the computer or the bench and back to the bedside. And this is in fact someone that I saw only a few weeks ago, a patient that had T-cell leukemia and heavy campatholemtuzumab exposure that led to bone marrow aplasia. He had a haploidentical hematopoietic stem cell transplant about 8 months ago from these presentations at Brigham and Women's Dana-Farber, and that was complicated by gastrointestinal graft versus host disease, for which he was taking tacrolimus and Jakafi. He was in fact being weaned from immunosuppression because over-immunosuppressed, lost his immune surveillance, was recently diagnosed by monomorphic EBV-positive post-transplant lymphoproliferative disorder. So just one step from diffuse large B-cell lymphoma, and he had got his first dose of rituximab. This doesn't just happen in Greece. Sometimes even in America, people who are immunocompromised get antibiotics even when they don't need it. So he had some sinus congestion, some symptoms. He was prescribed levofloxacin and presented to our hospital with acute onset explosive diarrhea, high fever. He was hypotensive, he had to go into the ICU. And at that point, his CMV surveillance, which he was updating weekly because of how immunosuppressed he was, that was only 3 days ago, was negative. Had a high lactate, he had a CT of the abdomen that showed severe pancolitis. There was no ileus. And if I was to put this in one of the board questions, I would ask, so how would you empirically treat this patient? What is the most likely diagnosis? Would you give ganciclovir or alvalside? Vancomycin, that's never the answer in the boards, but the most common approach to everything in real life. I think in Greece, zocin is called tazocin still. Or would you treat for C. diff with oral vancomycin intravenous metronidazole versus deficit and vancomycin enemas? So there is the misconception that all immunosuppressed patients sometimes can have any kind of common and opportunistic infections, and that's far from true. So it's very important when we have a differential diagnosis approach to start by identifying our host and then the syndrome. And then I usually like to build my differential by kingdom and always keep non-infectious causes in mind. But again, the most important part is identifying the host and the right syndrome. So the host with the red, the syndrome with blue, and this patient has several risk factors that would predispose him to any kind of CMV unhappiness, disease, syndrome, viremia. However, his syndrome doesn't really fit. So this is someone who, first of all, presents with very acute onset, massive diarrhea and fever, not something that gradually happened. And importantly, he had a negative viral load about 3 days ago. and a CT that shows significant colitis. Usually when you get to that stage, some of that CMV that's causing the colitis should also be in the blood. So you have a patient that's very immunocompromised, has risk factors for CMV, but in all likelihood, what he has was antibiotic-related diarrhea and what we call sometimes fulminant C. diff, or I personally like to call it C. diff sepsis. And I would say that if this was a board question, probably the last two options would be what we like to call a non-test question, see which one people would prefer. So it wouldn't be wrong definitely to say give oral fidaxomicin, because I personally and most people believe it's better than oral vancomycin. But because of how well the medications have been studied when we're dealing with fulminant C. diff and sepsis, still we recommend oral vancomycin and intravenous metronidazole. Not to mention that because those medications will have good bowel concentrations when there is no ileus, in general, we do not recommend vancomycin enemas unless the patient has ileus from C. diff. So the hosts that tend to get CMV roughly belong in three main groups. I will not give a lot of details because of time limitations about HIV positive patients in these presentations, organ transplant recipients, and obviously the highest risk are these patients that do not have CMV and immunity and get it from the donor, or those that have all their lymphocytes wiped out by hemoglobin induction. For hematopoietic stem cell transplants, we now call it hematopoietic cell transplant recipients, high risk is a little bit reversed because essentially they're picking the donors, the recipient's immune system, or if the patients have a cord hematopoietic stem cell transplant that's very lymphocyte depleted, or what we call myeloablative conditioning, meaning you wipe out their bone marrow, you don't have anything residual. And of course, there is the very interesting group of patients that are not transplant, solid organ, or hematopoietic recipients, but have other risk factors such as CAMPATH recipients, example for lymphoma, lemtuzumab recipients. And that was in fact one of Francisco's earlier studies to show these patients are high risk for CMV. Patients on high dose steroids, and sometimes we also see very late reactivations in organ transplant recipients, but we just see it in elderly patients or patients who have other comorbidities, especially if they are unlucky to get what we sometimes see primary CMV. So you think of the transmission of CMV, it's pretty much like mono. Most people will get it at a young age, but there is an increasing percentage, in fact, of people, it used to be about 20%, now it might be 30 or 40%, who will not see CMV. And sometimes that happens rarely in their life, later in their life, and they have other comorbidities or some mild form of immunosuppression. They can actually get very sick. So we have seen those cases, and it's important to always have that in the differential diagnosis. The clinical manifestations, as I said, it's often a mononucleosis syndrome with cytopenias. And that's important, especially in the transplant population, because ganciclovir and valganciclovir tend to cause cytopenias themselves, but it's usually a late side effect. And when the cytopenias are caused by CMV, they actually get better with treatment. So no reason not to give that. GI disease is probably the most common clinical manifestations, can be simple diarrhea, it can be colitis, usually the transaminases are a little bit elevated. Hepatitis can happen, but usually with herpes virus, when we see fulminant hepatitis, they kind of sometimes needs liver transplant. The patient's very, very sick. It actually comes from HSV, not from CMV. Esophagitis mostly in AIDS patients, retinitis as well. And of course, there can be unusual, uncommon manifestations that are like zebras or zebras with red and green stripes sometimes. One thing I would like to emphasize is there is this classic teaching that you can have tissue disease or GI disease without CMV DNA anemia, and that still applies to some cases, but is probably coming mostly from the old diagnostic methods, and I have some slides about that. So most of the time these days, if people have CMV disease, they should at least have a little bit of it in the blood because our PCRs are quite sensitive. Sometimes that's not the case in our positive patients because they have their own immunity to control CMV in the blood, but not in tissue. But that's something that I will discuss a little bit further in this presentation. And of course, there are the so-called indirect or immunomodulatory effects of CMV that may predispose the host to other opportunistic infections or cause organ rejection, because it does have its own elegant mechanisms of trying to evade host immunity and may make the host more immunosuppressed. But in reality, there is also a lot of confounding there because the patients who get CMV are overall immunosuppressed, and that can predispose them to other opportunistic infections. Often we adjust their immunosuppression trying to control the virus, and that may precipitate rejection. So it's a dynamic process, and I personally don't blame all of this to the virus. And this is a classic study from Hopkins. Christine Durant has also led the way in HIV in transplantation, and shows that among patients that all had a suspicion for GI disease and got an endoscopy with biopsies and all had CMV measured, it was actually much more common for people who had GI disease to also have detectable CMV levels and quite high. And depending on your pretest probability, which for most organ transplant centers will be somewhere in the 20 to 30% of CMV disease, you actually have a very decent negative predictive value, 95% or higher, for a negative CMV PCR in the blood. So with very few exceptions, if I see a patient that has GI symptoms and their CMV in the blood, a recent PCR is completely negative, I try to look for a different cause and not necessarily expose the patient to a colonoscopy or upper GI endoscopy to diagnose CMV disease. Again, as I said, there are exceptions, especially among the recipient positive population. And this was another study from the Mayo Clinic that showed in organ transplant and hematopoietic cell transplant recipients, again, the viral load of CMV correlates with the presence of symptoms and CMV disease, and it's quite uncommon, as you can see, when you have low-level CMV DNA, like in the tens or hundreds or even zero, to also have disease from CMV, with, again, few exceptions, and I will talk a little bit about those later in this presentation. Regarding this immunomodulating property, just a couple of cases. For example, this was a gentleman that we saw who had a kidney transplant. Similar to the first presentation, he also had late, so EBV negative, post-transplant lymphoproliferative disorder. His was, in fact, diffuse large B-cell lymphoma that required R-CHOP. He was in cycle 5. He had all the complications that you would expect on more febrile neutropenia, gram-negative septic shock, C. diff. He did have high-level CMV viremia with diarrhea and colitis. He was being treated for CMV, and then he was admitted in the course of this treatment with cough and shortness of breath. And of course, once again, he got vancomycin. But as you can see, and one can suspect in this case, his X-ray is not typical for bacterial pneumonia. And knowing what this patient had, you can extrapolate that he's very T-cell lymphocyte depleted, and in fact, had pneumocystis pneumonia. Now, is it that the CMV predisposed this patient to have pneumocystis pneumonia? Probably not. Probably it's the host who has 3 or 4 or 5 additive levels of immunosuppression, including his advanced age, the organ transplant, the lymphoma, lymphotoxic, lymphodepleting chemotherapy, and on top of that, CMV. So he's susceptible to various infections. And this was another lady that we saw at the point that we were not doing our own hematopoietic cell transplants. Now we have a partnership with the Brigham and Dana-Farber, and we're also doing our own autologous hematopoietic cell transplants. But back then, we were seeing mostly patients with hematologic malignancies, and they would follow at their transplant center. But that was a lady who had undiagnosed, advanced age, very low CD4 count, and at the time of diagnosis also had diffuse large B-cell lymphoma. So she was almost identical to a bone marrow transplant patient. And again, she was one who had many complications, including this interesting manifestation of CMV with high-level viremia and rhomboid glossitis. And here you can see the pathology of that lesions with the classic O's eyes, multinucleated cells that are considered pathogenic for CMV. So we're treating that. And then after all these complications, including respiratory viral infections that were pretty severe, but happened in the summer, which is very unusual, she presented with culture negative cystitis. And we said, you know, this is a syndrome that we see almost exclusively in bone marrow transplant patients, but she's not that far. And we diagnosed her with BK cystitis, polyomavirus cystitis. As you can see, the classic decoy cells, the multinucleated cells in the urine, and her urine and even blood PCR for BK virus was quite high. She actually responded to 1 dose of cidofovir that treated both the CMV at that point and her BK virus, as we treat hematopoietic cell transplant patients who have polyomavirus cystitis. Now, there's always the question, do we need to treat all CMV? What is the part of CMV that we treat and when? And as Dr. Sipsa said before, sometimes you may run into conflicting opinions, especially with the transplanters. I don't know how it is in Greece, but in the United States, sometimes, especially the surgical specialties, are more leaning towards treating than watching, and idea notorious for trying to be a little bit conservative and thoughtful and trying to sort things out. So I'll try and give at least my personal opinions on the literature about when to treat CMV. And then, of course, the question is, why not treat just everyone? And this is an overview of the most commonly used CMV treatments. And the answer is that, you know, they all have side effects and they're pretty severe. But at the same time, they don't happen immediately, probably with the exception of chronic toxicity, especially if someone also has impaired renal function and is receiving other nephrotoxic medications. So on the one hand, you don't want to expose your patient unnecessarily to the toxicities, but at the same time, it is a little bit of a time race. So you don't want to start treatment of CMV when the viral load is very high, the patient is already sick, you're expecting a long course to control it, and then you start hitting toxicities. And the nightmare is always when you don't have a very good control of the infection and you're having toxicity at the same time. So you cannot decrease the dose, or you have to choose foscarnet, which is more toxic. So in different patient populations, we may be more aggressive and start treating at an early stage when they only have the anemia. And these toxicities, of course, are the cytopenias with ganciclovir and valside, nephrotoxicity with foscarnet and cidofovir. And just for the board questions, most of infectious diseases, specialties, foscarnets can cause this unique scrotal erythema, especially in men. You basically pee the medication on the skin, and ortular hypotonia manifesting as anterior uveitis with cidofovir. And now we also have 2 additional medications that are FDA approved, maribavir for refractory resistant CMV, and letermovir, that was one of Francisco's, again, greatest contributions, which is approved for prophylaxis in high-risk allogeneic hematopoietic cell transplant recipients. So another case that's to demonstrate how sometimes we approach these patients, and one of the aspects of CMV management that I think is very promising in the way of the future. This was a lady that had a liver transplant many years ago. We didn't know the DR status at the time, but based on what she had, we could assume that by then she was R positive. For some reason unclear to us at the time, she was still on 3-drug immunosuppression. Livers, I tend to think of as the Prometheus story, that the eagle would eat almost all of it and then it would regenerate at night. They're the ones that usually require the least immunosuppression. They tend to reject the least of all organs, with lungs and bowel transplants, of course, being the worst. This lady was still on 3 drugs. She had this chronic cytopenias, and a part of the workup, she had CMV tested that for a few weeks was lingering somewhere there in the few hundreds to 1,000, a little bit more than 1,000. She didn't have any symptoms. And then the question was, do you treat or do you not treat? So I think that in selected cases, as time goes by and we get more experience, sometimes we feel comfortable saying this patient we can treat, we should treat this patient, we'll just observe, repeat the CMV viral load. But if we're looking for some kind of objective measure, I think assessing the CMV immunity and especially the T-cell arm is what is the most promising. In clinical practice, we usually face this need in 3 different scenarios. The one that I just described, you have low-level CMV anemia. You already treated CMV, and there is the question, do you just stop valside or do you give a lower dose for a few weeks, what we like to call secondary prophylaxis? And also primary prophylaxis, which patients need prophylaxis for CMV versus those who do not. And of course, there are some future directions, some research projects, especially with vaccines and adoptive immunotherapy, that unfortunately I will not have the time to discuss in this presentation, but I think they're definitely the way of the future. We actually have a special edition in this journal about the CMV T-cell immune assays that I serve as a guest editor. And the short story is we're trying to minimize the toxicities and costs when they are necessary of the medications. And sometimes the results can help us guide adjustments in immunosuppression. So even though the B cells and humoral immunity, and we know that from the old days that we're using cytogam and the CMV immunoglobulin play a role in controlling CMV, definitely the key part of the immune system in controlling primary infection, but even more so reactivation and relapse CMV after we stop the antiviral that controls the virus itself, as definitely the effector T cells. And these are supported, of course, by your CD4 cells. And we have roughly 3 categories of assays that can help us quantify this response. 2 of them are very similar to what we have to diagnose latent tuberculosis infection. So they measure interferon gamma production. The ELISpot or T-spot assays quantify interferon gamma producing T cells. So they reflect the functionality of aggregate CD4 and CD8 cells. Whereas the quantiferon is essentially an enzyme immunoassay, an EIA or ELISA, as we used to call it, that measures the amount of quantiferon and thus reflects mostly the CD8 capacity. There was this old school that we don't really use these days, pentamer kind of assay that was HLA restricted because, as you see, those were combined with MHC complexes. But a similar principle we use, especially at Brown these days, which is stimulation with synthetic human CMV peptide episodes, and then intracellular cytokine staining for specific usually for interferon gamma, and in our assay also the CD69, the Valor assay, and then separate quantification by flow cytometry. So this assay basically tells you the percentage of CMV-specific CD4 and CD8 cells in this patient. And applicable to the clinical scenario that I just described, both in organ transplant and hematopoietic cell transplant recipients who have low-level symptomatic, asymptomatic CMV viremia, a positive quantiferon is more indicative that this is something that we may not need to treat because the patient has capacity to control the virus on their own. And you will be seeing in some of my slides this nice Kaplan-Meier bars with a significant p-values, but at the same time, we always like to look at the predictive value of this test because it's a laboratory test. We need to have a cutoff. And you can see that there is a decent positive and negative predictive value, but there is always a trade-off with the cutoff that you decide to use in the production of interferon. And sometimes in certain hosts and populations, because there is a lot of overlap, we cannot say in a large proportion. But in this particular clinical scenario, the PPV and NPV are actually quite decent. So this is a test that we can use and make these decisions, especially the T-spot and the intracellular cytokine staining flow cytometry assays that will address the CD4 cell capacity are very useful because, as you can see, we need those CD4 cells to build a pool of memory cells that can more rapidly become effector cells and control the infection. So patients who have both CMV-specific CD4 and CD8 cells tend to control the infection better. And this was a small study that reflects that, although you can see across all three clinical scenarios that there is a trend for both CD4 and CD8 cells to be higher, CMV-specific CD4 and 8 cells to be higher in patients who can control and are protected from CMV. The difference is much more striking for the CD4 cells. And this again is a meta-analysis looking at the predictive value of various CMV T-cell immunity assays. And you can see that the T-spot is superior to the quantiferon. And this was a head-to-head comparison also published in the Journal of Clinical Virology. You can see how much better the ROC curves are for ELISpot as opposed to quantiferon-based assays. The assay that we use at Brown, as I said, the one that at least until recently was the only commercially available assay in the United States, was the one by Viracor. I have received funding from them for full disclosure. It's a CMV T-cell immunity panel based on the principle that I described. And you can see here on the top two CD4 flow cytometry snapshots, and on the bottom, the CD8. On the left, you can see negative 0.01%, as opposed to positive 1.9.92%, with a reference cutoff of approximately 0.2%. When we looked at the clinical utility of this assay, again, a non-blinded study at the time, we now have a blinded clinical trial looking at its utility, meaning the clinicians do not know the result of the assay. But we also observed that the CD4 percentage of CMV-specific competent cells were more useful than the CD8, although we also noted a trend for CD8 cells. And again, the clinical utility of this assay was pooled over all three clinical scenarios: low-level CMV viremia, secondary or primary prophylaxis. These are the ROC curves. And again, you can see how much better they were for the CD4 percentage of CMV-specific T cells. And in this ROC curve, you also see the absolute lymphocyte count, because that's something that has been suggested and sometimes is an inexpensive, readily available, useful test to see if your patient will be able to control CMV. But at least in our experience, again, depending on the clinical scenario, it wasn't as good as the CMV-specific T-cell immunity panels. And these were, again, the negative and positive predictive values, with a positive predictive value for protection in the mid-80s and negative predictive value probably in the high 60s. Again, depending on your pretest probability and how you think, how likely one is to have a CMV event that will require treatment. And interestingly, another study using the same assay from the University of Wisconsin came out with very similar positive and negative predictive values. So I think those estimates are rather accurate. Another important observation that is also reproducible from a study and others is that over time, CMV immunity becomes stronger. And that's something important to always have in mind. Some of it is triggered by the infection, by the viremia, and some of it is what we do to the patient. So our adjustments in immunosuppression. So in this particular case, she actually had very strong CMV-specific CD4 and CD8 responses. We did end up cutting down, stopping, in fact, azathioprine, and that also helped with the counts. And eventually, this was a patient who did quite well without any need for CMV treatment. Now, when we decide to treat CMV, again, I rarely give IV ganciclovir, although some may do if you have very high level viremia. We used to say 2 viral loads, undetectable, 1 week apart. Our PCRs these days are quite sensitive. The updated guidelines reflect that in most cases, in fact, 1 is probably enough. We monitor the patients weekly with the basic metabolic panel, the creatinine, electrolytes, sometimes LFTs, certainly their counts because they can have toxicity from ganciclovir, valganciclovir. Foscarnet is considered more cidal. Sometimes I have used it up front when we were suspecting even a simple herpes virus CNS infection that's catastrophic in a very immunocompromised bone marrow transplant patients, but it's also very toxic to the kidney. It's intense. We give it in inpatients, very rarely send people out on Foscarnet. I cannot emphasize enough the importance of watching for toxicities. It's not routinely recommended to get ganciclovir levels because they're quite predictable with the excellent bioavailability of Valsite, but sometimes in rare cases, I have done it if I thought that the patient was overdosed or underdosed, usually overdosed. We usually decrease immunosuppression starting with the antimetabolite, and there's a triple benefit to that. CMV often, as I said, comes with GI side effects, with GI symptoms. So stopping the mycophenolate, whether it's Salcept or Myfortic, helps with that. You're making the host a little bit stronger, and you also have less of a myelosuppressive effect. Depending on the patient population, you may have resistance or not. It's a bigger problem in lung transplant and, of course, in orthopedic stem transplant patients, not as much in our kidney and liver transplant patient populations. The classic teaching was that to get ganciclovir resistance, you had to be exposed for 6 weeks, but the Seattle group actually published a very nice CID study showing that in lung transplant patients in particular, resistance can happen even with shorter durations. But in general, you need ganciclovir exposure or Foscarnet to have a resistant CMV. And it's usually also some dosing issue because of side effects, because of toxicity, because of renal function. When I started probably fellowship in my general ID, there was still popular to give secondary prophylaxis after a target non-detected was accomplished with half-dose valganciclovir. That's fallen out of favor more these days. Sometimes we give 1 dose of cidofovir. Letermovir is a question. Maribavir, again, these days, mostly treatment for refractory resistant CMV. And I will speak a little bit more about secondary prophylaxis. Of course, T-cell immunity assays have their role here. And as I said, very recently, Maribavir is now approved for resistant refractory leukemia, relapsed CMV infection, and Xenia Papanikolaou's studies from Memorial Sloan Kettering played a big role in that. This was one of the studies from Tufts that showed probably secondary prophylaxis overall is not necessary. But if you look at those Kaplan-Meier curves, you actually see that you don't really have a proportional hazards assumption met. So in the first 6 weeks, there may be some benefit. So there are patients that you may consider putting on half-dose Valsite for a few weeks until they're immunologically stronger. And again, these are usually people that had a hard time controlling their CMV. You hit cytopenias. You're afraid of restarting treatment with full-dose Valsite. You're afraid of resistance if they are viremic and you have to use lower doses because you think they're going to get cytopenic. And in this clinical scenario and others is also, there may be a place for a CMV T-cell immunity panel. And this was one of the AGT studies that shows using the quantiferon may predict patients who will relapse after stopping Valgan or not. But again, what's interesting here is that you see the people that had negative quantiferon relapse even after secondary prophylaxis. So probably the target here should be their maintenance immunosuppression, how this can be reduced without risking the graft, as opposed to giving more antiviral. And again, the Tufts folks showed that the absolute lymphocyte count, as I said, may be able to predict the risk of relapse. And they found that with an ALC of more than 1.75, you can be almost certain that the patient is not going to have any issues with CMV after you achieve control with Valsite. But going back to my previous point, how many of our patients have an ALC of 1.75? And these are beautiful Kaplan-Meier curves, but there's also a lot of overlap. You can't really come up with a cutoff because most of your patients will have an ALC in that gray zone, that there is overlap between those who relapse and those who don't. A couple of words about antiviral resistance. There are two major groups, CMV DNA polymerase, the UL54 as we call it, and UL97 that confers resistance to ganciclovir, whereas the UL54 mostly for scarnet or ganciclovir and cidofovir resistance. At MD Anderson, we would see multi-drug resistant CMV quite often, and this is one of the scenarios where it may be useful to resort to maribavir, or what I find is the most promising, adoptive T-cell immunity, CMV, potent, specific, off-the-shelf these days, T-cells that can be given to these patients. So this is another common scenario. This was an allo ACT patient, positive, so probably intermediate risk, but he was high risk because of graft versus host disease. He was on high-dose steroids. We were not afraid of valside because he had very good engraftment normal counts. And he had a blip of the CMV. Next week, it's tripled, even though the patient is asymptomatic. This is someone that you know probably will progress to significant viremia. And because of their counts, you really don't want to keep them on valside too long, high-dose treatment dose valside. And you start at about 900 copies per ml. So the next week, the hematologist calls you and says, hey, this patient has now more CMV than he did before valside. I am concerned. I want to bring them in for scarnet. So do you say, sure, yes, admit the patient to the hospital? Do you say, stand back. It's okay. Let's give valside for another week. Switch to IV ganciclovir. Double the dose of ganciclovir because you're concerned for resistance since the assay. And to answer that question, we actually have now very good definitions. Roy Shemali from MD Anderson was the first author in that. And there are two main groups of CMV unresponsiveness, to put it like that, to treatment. So resistance is when you actually have the mutations that define decreased susceptibility to certain antiviral drugs. And we also have what we call refractory CMV infection, where even in the absence of resistance, you just can't control the viral load. But it's very important to say that this is a PCR. Things vary, and they vary by logs. So we think in logs. So when there is more than one log increase, we call it refractory. When it's less than one log increase, we call it probable. Similar, when we're looking at CMV disease and clinical presentations, if the patient is worse, then yes, you call it refractory. If they're same, but not better, you call it probable. It is very important to emphasize that those viral loads need to be with the same assay and the same lab. We're transitioning at Brown now from ARUP CMV PCRs to using in-house PCRs. I don't remember which platform, but the platform that we're using for in-house PCRs, in fact, gives us almost always at least one log less than the one at ARUP. So that on its own doesn't mean anything. But it's also very important to emphasize that we can't be talking about resistant or refractory CMV unless the patient has received at least 2 weeks of appropriately dosed antiviral treatment. Sometimes the patients are getting lower treatment, lower dose because of the renal failure. The kidneys have improved. The dose wasn't adjusted. We see the viral load lingering there. That's not refractory. That's not resistant. And in this particular case, this has just been 1 week. In fact, it was less than a week, and you don't even have a log rise in the CMV. And this is what is expected in the normal variations. It might even be an interassay variation. So we kept this patient on the same dose, and he controlled the CMV beautifully, and eventually was just transition to secondary prophylaxis. So as Hippocrates would say, prophylaxis is always preferred to treatment. And again, it's a long topic, but some of the selected points that I have 1 or 2 slides about is, one, using a lower dose of valside, at least in our positive organ transplant patients. Preemptive, believe it or not, no valside, just checking CMV viral loads. Letermovir, that as I said, was one of many contributions made by Francisco Martin in the field. And just for historical purposes, there was an early New England Journal of Medicine paper. David Steinman from Tufts was the first author of using anti-CMV cytogamma Ig as prophylaxis. Some places would still use it adjunctive in very severe CMV to antivirals. I've only used it probably once or twice. I don't think it's necessary. And of course, high-dose Valtrex, and by high dose, I mean 2 grams Q8 as opposed to sometimes in Q6, but that usually comes with significant neurotoxicity, especially in people that may have an impairment of the renal function. There was an earlier meta-analysis, and even though it has not been formally adopted by the guidelines, ourselves and Brigham and Women's Hospital also usually choose valside half dose for prophylaxis. We do it for our positive patients because I'm still a little bit skeptical for D plus or minus. But since we started doing that, we actually did not see any increase in our incidence of CMV viremia, let alone disease, and it is quite cost effective. Meta-analysis even suggests that it may be effective in decreasing the cytopenias and other side effects. One of the most important studies, I think, of the last couple of years was this preemptive versus prophylaxis CMV study in liver transplant patients. Again, as I said, livers are usually the easiest of transplants when it comes to managing opportunistic infections and immunosuppression. So patients were randomized to receive preemptive therapy, meaning they were getting their CMV viral load checked regularly every week, and if it became positive, they were immediately switched to treatment dose. This slide actually has a mistake. It's a JAMA slide. It's not my slide. It wasn't prophylaxis. It was treatment dose. Or give them for the same duration, 100 days, antiviral prophylaxis, non-check CMV, stop it and see what happens. So you can take 1 or 2 seconds to predict which arm did better. And one would actually guess, it's not unreasonable to predict that it was the patients who got the preemptive therapy. And why is that? Because we're looking at CMV disease. We're not looking at CMV anemia. And that's, I think, a very important message, that you catch it early on, you can control it, and you're probably also helping the host by triggering whatever immunity they may have. So the patients that receive preemptive therapy within the first 30, 40, 60 days developed CMV viremia. They were treated, they got to target undetected. Their treatment was stopped. They didn't progress to CMV disease, as opposed to the patients who received prophylaxis and commonly present with CMV disease, what we call late CMV disease, after you stop the prophylaxis. And this is quite clear in these Kaplan-Meier curves, where you see the period of intervention was the first 100 days. And in fact, there were a few patients in each group that even developed CMV disease, probably syndrome that's also a little bit controversial because it's more like a flu-like syndrome when you happen to have a CMV anemia, maybe from another cause. And there were some dosing issues, especially in the prophylaxis group, because it's highly unusual, again, outside of lung transplant and bone marrow transplant patients to see CMV while someone is on prophylaxis. But as you can see, the patients that received preemptive therapy had significantly lower incidence of late disease. Now, this is the trial setting, and in real life, some people may say, I don't know if we can get those weekly or twice weekly PCRs for CMV. I still go with prophylaxis, and that's where we also stand for our kidney transplant patients. And some centers like Brigham for the heart transplant population, even when the distance and said, hey, look at those Kaplan-Meier curves. Whatever happens in the first year. Why don't we just extend our CMV prophylaxis by a year? And in fact, that's what most centers will do for lung transplant, high-risk lung transplant patients. So all other organs will get 3 months of valside if they are positive, 6 months if they are donor positive, recipient negative. For lung transplant patients, you double that. And CMV prophylaxis is extended to 1 year for high-risk plus or minus patients. And believe it or not, there were centers like UT Southwestern and Dallas that until recently were giving those patients valside for life because of the late CMV activation. And we don't know if the strategy is effective, or even if after 1 year, then you stop it and you get late CMV that's very late. It's now beyond stopping prophylaxis. But it's also that 1 year is critical for immunosuppression. And if you can adjust it down the road, you can probably control CMV better. But it is important to show here, ignore this last bottom right panel, they messed up the colors, that the yellow seems to be a lot better than the blue. And you can see these are certain metrics of T-cell immunity, again, that the patients who received the preemptive approach, because they were allowed to have low-level CMV anemia, also were able to mount an immune response that probably helped them control it and not progress to CMV disease. And this was another older study looking at, again, the quantiferon in predicting the risk of CMV after stopping prophylaxis in the D plus R minus organ transplant population. This is an interesting graph because you see those who did worse were actually the ones who had indeterminate quantiferon. And again, that's not surprising because These were the people that didn't even respond to the mitogens, so even more immunosuppressed. But even when you pull blue and red together, there is still statistical significance. However, as I said, yeah, those Kaplan-Meier's look convincing, but if you're going to establish a threshold, it's not that easy, especially for the quantiferon, because even though the difference in numbers is statistically significant, there is a lot of overlap. And you can see that the positive predictive value is great, and it makes sense. Like if you're D plus or minus and you get a positive quantiferon, which means you develop immunity to CMV without getting sick from it, you're very well protected. But most of these patients will be negative because they haven't had CMV disease. They were suppressed by prophylaxis or by another mechanism. And still, a lot of these patients will not develop CMV. So that's not as much of a useful result. And that's why it's not routinely recommended to use these assays in D plus or minus patients. And this was another example that, again, you see those great p-values, but if you want to establish a cutoff and you look at the ROC curve, it's not that predicted. And another approach, again, similar to what I said, will be, how about we check quantiferons or something else, the T-cell immunity assays every 3 months, and when it becomes positive, stop prophylaxis or extend, and there is no wrong or right answer, extend to 1 year, extend beyond 1 year. But in this study, at least, it was shown that probably you get a small benefit in less late CMV if you extend prophylaxis in patients who have a negative T-cell immunity assay. And last and not least, a couple of things about letermovir as prophylaxis. It's now approved in allogeneic hematopoietic cell transplant recipients. It has its own unique mechanism. As I said, the UL56 terminase inhibitor. The terminase as an enzyme is unique to CMV, not other herpes viruses. So we do need to give HSV prophylaxis on top of that. Those patients get Valtrex or acyclovir. It's certainly more beneficial, even though the study, the classic study by Francisco Marti, showed a benefit across all groups in high risk, such as recipient positive, mismatched, haplo, meaning those that pick up a negative donor's immune system and they have their own CMV, haploidentical transplants, severe graft versus host disease, the umbilical cord transplants, T-cell depleted. We have limited experience in other hosts, but we know that it's a medication that is not extremely effective against raging CMV. It has a low genetic barrier for development of UL56 mutations. And unfortunately, we've even seen what we call compartmental reactivation, meaning patients that may not have CMV DNA or have very low, more commonly than none, CMV DNA load in the blood. But we actually had one of the Brigham allogeneic stem cell transplant patients present with severe encephalitis, classic MRI findings, very high CMV viral load in the CSF, and all of this while she was taking letermovir. And there are also raised reports of endoarticular infections, eye infections, and pneumonia, because we think that probably letermovir is not that effective in controlling CMV in tissue. And as I said, unfortunately, I don't have time to talk about what I consider the future directions for CMV, but definitely we're excited about the prospect for CMV vaccines. I do think that adoptive T-cell immunity is a modality of the future. So development of T-cells that will specifically attack not just CMV, but these days also EBV, adenovirus, hard to control viruses with other antivirals. They're actually a very promising strategy for EBV positive post-transplant lymphoproliferative disorder, where you're not going to work with antivirals. That's a very interesting model. You actually give more immunosuppression, give rituximab in a viral illness, because it's not the virus that is cytotoxic, it's a virus that's transforming the B cells into lymphoma, and you just want to wipe out this reservoir before its full diffuse large B cell lymphoma takes over. That's what also these T cells do. They will attack the lymphomatic cells, almost like CAR T cells that are EBV specific. And again, we have that for CMV adenovirus and even for BK. And I know that there were a couple of clinical trials that we're hoping to get our hands of anti-CMV monoclonal antibodies as well.
Δημήτρη, σε ευχαριστούμε πάρα πολύ. Πιστεύω ότι έδειξες πώς είναι να είσαι λοιμοξιολόγος και να ασχολείσαι με ασθενείς οι οποίοι είναι ανοσοκατεσταλμένοι και πόσο αυτή είναι μια πολύ μεγάλη ομάδα ασθενών όταν συλλέγονται και θα πρέπει να έχουν ανθρώπους που είναι εξειδικευμένοι με αυτό. Υπάρχει μια ερώτηση από το κοινό, έχουμε ξεφύγει λίγο από το χρόνο, με κοιτάει εδώ ο κ. Κοφτερίδης με ένα στραβό βλέμμα.
Εμένα πρέπει να κοιτάει, συγγνώμη.
Έλα, το παίρνω όλο πάνω μου. Το έβαλε σωστά το Levine?
Ναι, δεν θα...
Γιατί κάποτε είχα βάλει ένα στο πνεύμα εγώ και λέω, υπάρχει μια ερώτηση σε παιδιά με ανοσοανεπάρκειες, θα έδινες μαζί με την αντιοική αγωγή και υπεράνωση σφαιρίνη έναντι του CMV, θα βοηθούσε αυτό το πράγμα?
Συνήθως δεν δίνουμε IVIG. Σε ελάχιστες περιπτώσεις έχω δώσει cytogam, που είναι anti-CMV specific immunoglobulin. Αλλά όσο έχουν περάσει τα χρόνια, αυτό το έκανα στην αρχή που ήμουν και λίγο πιο ανασφαλής. Πιστεύω ότι τα αντιοικά είναι πάρα πολύ... They're very potent. They're very potent, they're very effective. Ποτέ δεν λέω όχι. As a rule, no. I wouldn't do it in everyone. Αν είχα κάποιον ο οποίος ξέρω ότι με το Valsite έχει μεγάλο πρόβλημα, γιατί δεν θα μπορέσω να το ελέγξω, είναι ένα approach. Δηλαδή, ρίχνεις το οικό φορτίο και δίνεις again, either T-cells or cytogam or something to control the virus, because every time you give them Valsite, the neutrophil goes down to 0 and they get neutrophilic fever and sepsis. But otherwise, antivirals against CMV are very potent. I think that on their own, they're usually pretty good, and at least that's been most of our practice. There are centers, as I said, that like Baylor University Hospital in Dallas for a while, when they had CMV pneumonia, they would give everyone cytogam. Again, that's kind of a preference and style, so probably not. Probably not.
Και για να κλείσω να σε αφήσω και να σε ευχαριστήσουμε ξανά, να δώσω ένα μήνυμα στους ανθρώπους που ασχολούνται με την HIV λοίμωξη. Έχουμε ένα κριτήριο της ανοσοκαταστολής, είναι τα CD4, είναι εύκολη η ζωή για μας. Και το μήνυμα της ομιλίας του κ. Φαρμακιώτη σήμερα ήταν το πόσο σημαντικό είναι να βρεις έναν τρόπο ώστε να αξιολογήσεις τον κάθε ασθενή ξεχωριστά, με αυτόν τον τρόπο να δεις ποιοι υπάρχουν περίπτωση να έχουν ένα νοσοποιητικό που θα ανταποκριθεί από μόνο του και να ξεχωρίσεις και να μην βάζεις στο ίδιο καζάνι όλους τους ασθενείς. Πιστεύω ότι αυτό είναι το πιο σημαντικό πράγμα, το μήνυμα αυτής της ομιλίας, ότι αυτό είναι που πηγαίνει και η ιατρική, ώστε να είναι εξατομικευμένη, και με αυτά τους τρόπους που μας έδειξες, πιστεύω ότι εκεί βαδίζει η σύγχρονη ιατρική.
Ναι, είναι ακριβώς αυτό που λέω. We are a little bit beyond evidence-based medicine, and our generation is about precision medicine. That's exactly what you...
Μια ερώτηση, Δημήτρη, μόνο από τον κύριο Σύψα, ένα λεπτό, για να κλείσουμε.
Ευχαριστούμε πολύ για την παρουσίαση. Θα έχω μία ερώτηση με 3 σκέλια. Το πρώτο είναι ποιο είναι το interplay ανάμεσα στο CMV και στο GVHD. Δηλαδή, τι κάνει το ένα και το άλλο. Δεν ξέρω, το GVHD και η θεραπεία του ενεργοποιεί το CMV. Σημαίνει και το αντίστροφο. Αυτή είναι μία.
Ναι, αυτή είναι εξαιρετική ερώτηση. Εξαιρετική. Όπως είπα, υπάρχει τεράστια βιβλιογραφία για τα indirect effects of CMV. It has its own mechanisms of making the host weaker, and in that setting, maybe the graft can attack, and especially in the GI tract, which is the main area for both, there is an interplay. But at the same time, because of how these patients are and how immunosuppressed, especially after you start treatment for graft versus host disease, it's hard to tell what is the chicken and the egg. And again, it's especially, graft versus host disease is immunosuppressive on its own because the graft is attacking the host. So that involves the host's immune system, whatever's left of it, also the thymic reservoir. So there is an interplay. Definitely when you see GVHD patients, that's also another kind of misconception going back to Simon's point. You say, oh, they're many years after the bone marrow transplant, but if they have graft versus host, they may be more immunocompromised than someone who just got their graft a few months ago, but everything's going smoothly. They don't have GVH. They're probably even more immunocompetent than people who are years into the transplant that have graft versus host disease.
Και το δεύτερο σχόλιο είναι η μελέτη του Letermovir έδειξε επίσης all-cause mortality reduced in patients receiving Letermovir.
Ναι, there was a signal.
Any comments?
There was a signal. Francisco used to be very proud of that. Probably, It was also, from what I remember, an earlier signal. Like, I don't think it was carried all the way to the end of the study. I don't remember if that was the first 12 or 24 weeks, but there was also a signal for decreased all-cause mortality. Going back to your point about graft-versus-host disease, for example, CMX was brincidofovir. The phase 2 trial was very promising, but then when the phase 3 trial came out, there was a lot of diarrhea, and whether that had something to do with more graft-versus-host disease or diagnosis of graft-versus-host disease, the medication unfortunately failed miserably, and that's why, you know, it's not used for CMV prophylaxis or treatment anymore. So that shows, as I said, the interplay between anything that can trigger inflammation in the bowel and graft-versus-host disease among the allogeneic transplant recipients. And of course, you know, the microbiome is another interesting world of its own, worth thousands of hours of presentations.
Η τελευταία σύντομη ερώτηση είναι ότι βλέπω ότι δίνεται oral Balkan cyclovir. Εμείς το δίνουμε μόνο σε ασθενείς που είναι χαμηλού κινδύνου. Σε ασθενείς υψηλού κινδύνου δίνουμε IV. Το Balkan cyclovir στα 5 επίπεδα. Και υπάρχει, νομίζω, και η Γενοβέφα Παπα-Νικολάου έχει πει ότι όταν είναι υψηλού κινδύνου δώσει IV και είναι μόνο για χαμηλού κινδύνου τα 900/2. Ποια είναι your take on this?
I think some of this originated in certain centers, like in the liver transplant patient population. As I said, it wasn't actually because the studies for Valsite were done mostly in kidney transplant recipients. It wasn't approved, and for many years there were issues with insurance coverage. So certain centers, again, as I said, in Texas, would even say, you know, we can't get the insurance approved for the patient to get Valsite at home, and we give them IV ganciclovir, we bring them to our infusion, we eat up the cost because, you know, they're transplant patients, we give them IV ganciclovir almost every day. But my personal take, at least, is that Valsite is an excellent medication if used correctly. Again, the most immunosuppressed patients, like you have a lung transplant patient who got Campath induction and they're on augmented immunosuppression, we have them on Valsite D+ or minus. Yeah, they may get breakthrough CMV, and these are the patients that may also get resistance and become a nightmare. And then, you know, their kidneys are also failed from high tacrolimus levels and have to give foscarnet. But in the majority of patients, I would say probably over 90% of my experience, I think oral Valsite is excellent. And in some cases, the JAMA study showed, Nina Singh study, said that if you can, that's kind of my rule, if you can follow CMV close, if you can get viral loads frequently enough, and you know that treatment will not be delayed, and insurance will not give you a hard time with Valsite, maybe you can do a T-cell immunity panel, but the rule is you can manage them successfully. But close follow-up is, I think, key here. Close PCRs. Very rarely patients will get from undetectable to hundreds of thousands and sick in a matter of days. And that's only in D+ or minus. You catch it early, you will control it. At least that's my rule.
Σας ευχαριστούμε πολύ.